Hi, welcome to the NEET PG Core Revision Series in Pharmacology, where I am going to take you through all the important topics for the upcoming NEET PG examination. So today we are going to discuss about anti-diabetic drugs. So first we are going to do the classification. So what are the different anti-diabetic drugs that we have? So we have the oral anti-diabetic drugs. Here the drugs which are going to enhance the insulin secretions. Here we have number one, the drugs which act on the ATP sensitive potassium channels, or they are going to block them, which are sulfonylureas and meglitinides. Then we have drugs which are going to inhibit the DPP, the enzyme which is responsible for metabolism of GLP. So these are your gliptins, DPP4 inhibitors, sitagliptin, vildagliptin, etc. Then we have drugs which are going to overcome the resistance. These are bigonides, which is metformin, thiazolidinedione, that is pioglitazone, then drugs which inhibit or retard the absorption of carbohydrates from the intestine, which are your alpha-glucosidase inhibitors like acarbose, voglibose, miglitol, and very important drugs which promote the excretion of glucose, right? So these are your glucose SGLT2 inhibitors. So these are your gliflozins. Very important for the examination point of view. So now we are going to first do this MCQ which was asked in the previous year paper. Which of the following drugs is least likely to be associated with pleural complications? Metformin, methisogide, bleomycin, nitrofurantoin. So out of them, metformin is the correct answer. It has nothing to do with the pulmonary, very least likely to be associated with pulmonary complications, while the others like methisogide, bleomycin, nitrofurantoin, all can lead to your pulmonary complications like fibrosis, etc. Okay, so this was one of the previous year questions from this chapter. All right, moving on to the various drug groups and very important features for each one of them we are going to highlight. So first one is sulfonylurea. Now sulfonylureas, they actually have two generations. The previous one, which is no longer available or no longer used, we have the first generation sulfonylureas and the second generation, the newer ones that we are using in the currently. So glimepiride, gliclazide, glibenclamide, all of these actually are your second generation drugs. Second generation sulfonylureas. So what is the mechanism of action of second generation or sulfonylureas as such is, so sulfonylureas, so this is actually a beta cell of the pancreas, right? So beta cell of the pancreas, you know that it causes release of insulin whenever there is glucose when it comes in, so that triggers the release of insulin. So in your diet, when you eat any diet or food which consists of carbs and the glucose is released, so by GLUT2 it gets transported inside the beta cell of the pancreas and it leads to release of insulin. Now, what happens in case of when you're going to give it to the diabetic patients, you want to enhance the insulin release here. So, we give a sulfonylurea. This is sulfonylurea drug. Now, on this beta cell of the pancreas, there are channels which are called as ATP sensitive potassium channels. So, when sulfonylurea is given, it acts on its receptor, which is called sulfonylurea receptor. So this receptor is present on this channel. So when sulfonylureas bind to this, they are going to cause the closure of this channel. So they are going to close this ATP sensitive potassium channel. You know these potassium channels, the potassium normally moves from inside the cell to outside of the cell. So when this channel is now blocked, this potassium ion will be accumulated inside, and when this potassium ions accumulate inside, there's going to be increase in the positive charge, right? So this causes depolarization of the membrane. It leads to triggering or of the stimulation of the voltage gated calcium channels and leads to entry of calcium inside the cell. This calcium entry inside the cell, it leads to release of the stored insulin, and that is how insulin is released. So they are insulin releasers. That's how we call them. They are insulin releasers, and they block the ATP sensitive potassium channels. Now, this insulin release is independent. This is independent of the glucose, blood glucose, independent of blood glucose. What it means is, even when blood glucose is there or not, it doesn't depend. That's why the chance of hypoglycemia is really, really high with this group of drugs. So, therefore, there is increase in the risk of hypoglycemia. Okay, so this is one of the major adverse effects. So, any drug which is going to cause the release of insulin, mostly you will see their side effect. One main side effect is hypoglycemia, and secondly, because insulin is an anabolic hormone, it can lead to increase in the weight. So, it causes increase in the weight. So, weight gain is there because of insulin being a anabolic hormone. So, these two are the important side effects we need to be very, very careful with: hypoglycemia and weight gain. So, therefore, if the patient is already obese, you would not like to give this drug. Now, just a one line about the first generation drugs, which are now no longer used now. So, the first generation sulfonylureas were tolbutamide and chlorpropamide. So, only thing I would want you to know about this is that this chlorpropamide is responsible for SIADH, and it can lead to disulfiram like reaction. And tolbutamide, it follows zero order kinetics. So, these are the important things that you need to know about this. Now, moving on to the second group of drugs, we have meglitinides. So, meglitinide, they work by a similar mechanism just like sulfonylureas. So, they also block ATP sensitive potassium channels, but their receptor site is different. Otherwise, do the same thing, right? Now, what is the difference from sulfonylureas? Sulfonylureas are slower acting, while these are rapid acting. These are rapid acting and they have a short duration of action. So, therefore, they are used for treatment of post-meal or postprandial hyperglycemia. So, it needs to be given before the meals, right? So, given before meals. And if the meal is skipped, suppose the person is not going to have the meal, then you are going to skip this drug as well. Otherwise, similar problem, the adverse effect it can cause is, major problem is hypoglycemia, especially if you combine with the drug, another drug. Then we have GLP-1 agonists. Now remember, GLP-1 agonists. So what is GLP? GLP is endogenous in our body, and GLP-1, the role of GLP is to increase the glucose dependent, right? Remember, it is not independent, glucose dependent insulin secretion. That is number one. Number two, GLP-1 also decreases the gastric emptying. So, the patient will be feeling full for some time, right? For a long period of time. Also, it increases the satiety by acting on the hypothalamus, which means that patient has a feeling of fullness. So, GLP-1 agonist means they are going to mimic this action. So, they are going to mimic the endogenous GLP-1, right? So, endogenous GLP-1. So, this is how they are going to act. This is their mechanism of action. Now, these group of drugs, they have a low chance of, they have low incidence of hypoglycemia. hypoglycemia. All these drugs are given by the subcutaneous route except semaglutide, which also is given by the oral route. So what are the ADRs associated? So GIT ADRs like nausea, vomiting, pancreatitis, weight loss, and this weight loss has been put into use now. So these drugs, because of this weight loss feature, they are also used now, approved for use for obesity. Okay. Contraindication to the use is like if the patient has a history of or has thyroid cancer or family history of medullary carcinoma, MEN2 syndrome, then we don't recommend this drug. So contraindicated in thyroid cancer. Okay. All right. The next we are going to do about one or two drugs important just to know the names and their uses. GLP-2 analog. So they were GLP-1, the GLP-2 analog. We have a drug called as teduglutide. So this is a GLP-2 analog and it increases the intestinal mucus growth. Sorry, mucosa, not mucus, intestinal mucosa growth. Therefore, it is used for short bowel syndrome. It is not used for as an anti-diabetic. It is used for short bowel syndrome. So remember this about teduglutide. Then we have a drug which has a dual action, acts on GLP-1 and GIP-2. Similar actions to both, so there is doubling of the action because we know what is the action of GLP-1. GIP also causes increase in the insulin secretion. It increases the fat metabolism and it also increases the insulin sensitivity. So this is because of GIP. So it is combining the effect of both GLP-1 and GIP. So it has a very stronger action as compared to alone GLP-1. So their use is for diabetes with obesity. So they are anti-diabetic and if the patient is obese, they help in the weight loss of the patient also. So this is a important use of your GLP-1 and GIP analog. Oh, the drug, yes, the drug which is important here is tirzepatide. Okay, tirzepatide is a drug which is GLP-1 and GIP analog. Remember, it's an important drug to know. Then we have DPP-4 inhibitors. Now, what is DPP actually? So DPP is an enzyme which metabolizes GLP-1 and GIP. So if you want to increase the level of GLP-1 and GIP, you give an inhibitor of this enzyme DPP-4. So when we give these drugs, they are going to inhibit this enzyme, right? And therefore the level of GIP and GLP-1 will automatically be there for a longer period of time. So that's what they mostly, that's how they work. So the drugs are also called as gliptins, right? Because the suffix is gliptin for all these drugs. Sitagliptin, saxagliptin, linagliptin, vildagliptin and allogliptins, right? Okay, so remember saxagliptin, it is not used because or it has a higher tendency to cause heart failure. Vildagliptin banned because it was hepatotoxic. All of these drugs also will have to be monitored for their liver function tests. Therefore, while the patient is on these any of this drug, right? So, what they do, we have increased the GLP-1 and GIP. So, they also increase the glucose dependent insulin secretion, right? So, that's there. mechanism of action. So what are the adverse effects? So the most common adverse effect linked to them is nasopharyngitis because of the substance P accumulation, and this is the most common. Then rare is there, but pancreatitis they can cause, though it is rare. I told you all of them we have to monitor them for hepatotoxic potential as well. So hepatotoxicity, and they can have a tendency to increase the risk of heart failure. So we have to be careful in them. Now remember that these drugs, they are weight neutral drugs. So there is no increase or decrease in the weight. So these are weight neutral drugs, right? Very important to know. All are contraindicated in kidney disease except linagliptin and another is tenagliptin. So all are contraindicated in kidney disease or renal disease except linagliptin and tenagliptin. Becomes an MCQ question. Exceptions you have to know which of them is not contraindicated or it is safer to be used in renal disease. So other drugs which are safe or anti-diabetic drugs which are safe in the kidney or renal disease or renal failure, yeah, these two we've done, tenagliptin, linagliptin, then albiglutide, semaglutide, dulaglutide and pioglitazone. These are other antidiabetics safely which we can give in the renal failure. Moving on to the next important drug, which is an insulin sensitizer, that is metformin. So they belong to the group of drugs called as agonists. Initially before metformin we had fenformin, but that was withdrawn because of the risk of lactic acidosis. Now metformin, it is an insulin sensitizer and it is called as an anchor drug. What is the meaning of an anchor drug? That this forms the base, and or we keep on adding the other drugs around this base. So this is, that's why it's called for the anchor. So mostly used with most combination therapies. Used with most combination therapies. Now it is a drug of choice for type 2 diabetes mellitus until unless there is a contraindication. Now it is also used for other conditions like PCOD, polycystic ovarian disease, where it leads to decrease in the insulin sensitivity. Then non-alcoholic fatty liver disease, again it can disease the insulin sensitivity. Then in typical antipsychotic induced metabolic syndrome, where there is weight gain or there is increase in the blood glucose levels, there also these can be used. Now how they work exactly is by stimulating an enzyme, AMP kinase, and this is going to cause inhibition of the gluconeogenesis. Also they increase the peripheral glucose utilization, and it also decreases the absorption of glucose from intestine. So these are the main roles of metformin, how they work, how this works actually. Adverse effect, the most common adverse effects seen with metformin are the GIT ADRs, like that is the diarrhea, most common. Others, because it decreases the absorption of not only glucose from the intestine but also the vitamin B12. So it can lead to megaloblastic anemia because of decrease in the absorption of vitamin B12. Now, in an otherwise healthy patient, this lactic acidosis is not seen with metformin. But in case there are certain group of patients or there are certain diseases which are in the patient, then the risk of lactic acidosis will go high. So, it can cause lactic acidosis if the patient has any kind of hepatic or renal disease. If the patient is of COPD, smoker patient also, patient is in shock, alcoholics like CHF. So in all these, if there is diabetes with any of these conditions, then metformin is not a safe drug here because it can increase the incidence of lactic acidosis and such. You'll have to stop giving the drug here and look for some other alternative. Moving on to the next group, which is your thiazolidinediones, and the other name is glitazones, because all of these drugs, they end with the word glitazones. We have pioglitazone. This is the only drug available in India, right? Troglitazone was there, but no longer because it is hepatotoxic. Rosiglitazone in India is not used because it has increased risk of myocardial infarction. So only drug here we have is pioglitazone. And what is the mechanism of action of pioglitazone or thiazolidinediones? That they stimulate the PPAR gamma receptor. PPAR gamma receptor, which is actually a nuclear receptor. And this is present in the adipose tissue, on the muscle and on the liver as well, but mainly on the adipose tissue and the muscle. So what it does is, it will increase the peripheral utilization of glucose in these tissues, increases the peripheral utilization or uptake, what do you call it? Peripheral utilization or uptake of glucose in these tissues. Therefore, it will increase the, what do you call that? Insulin sensitivity. Increases the insulin sensitivity. All right. So this is the role of these drugs. Now we have a drug which not only is an agonist on the PPAR gamma but also an agonist on the PPAR alpha. So the drug name is saroglitazar. Saroglitazar. Saro means Sara. It both alpha as well as gamma agonist, right? Saroglitazar. Another we have allegretazar. Alle means all. In English, Sara means all. So Saro and Alle both, they are going to block both PPR alpha and gamma. They are going to stimulate both receptors. Now, gamma function, we know that it stimulates when the PPR gamma is stimulated. It leads to increase in the insulin sensitivity. But what about alpha? So this alpha, it is PPR alpha. They are going to stimulate an enzyme called as lipoprotein lipase, and this is involved in the breakdown of triglycerides. So they cause breakdown of triglycerides. So it is going to be helpful therefore in case of dyslipidemia. So diabetic dyslipidemia, this is the drug we can give because it takes care of the diabetes as well as the dyslipidemia. So the use is diabetic dyslipidemia. Okay. Now, what is this major adverse drug reaction with this? So, ADRs, they lead to sodium and water retention. So, they cause sodium and water retention. So, because of this, they can cause weight gain. Number one, because of this, it can precipitate congestive heart failure. So, absolutely contraindicated in patients who have already there is a history of heart failure. Then In postmenopausal females, it can increase the risk of fractures, bone fractures. Then hepatotoxicity. Pioglitazone, if we use them for a long period of time, like more than 2 years, there is associated increase in the risk of bladder cancer. More than 1 year use of pioglitazone. So these are the important adverse effects which you need to know about thiazolidinediones. Coming on to the next important and very, very popular group these days, that is gliflozins or SGLT2 inhibitors. So these are canagliflozin, dapagliflozin, empagliflozin, and ertugliflozin, sotagliflozin. Now remember this SGLT2. What is the role of SGLT2 here basically is on the kidneys. There is this transporter, SGLT2. Now SGLT2 transporter, it can lead to transport of sodium and glucose inside, right? Now what these inhibitors do, they are going to inhibit the transporter. So whatever sodium and glucose is there, it is going to then be excreted out. Sodium, right, and glucose. It's going to be excreted out, so there will be increase in the level of sodium and glucose in the urine, but it is not going to be transported back into the body. So this is how they work, right? Now, because of this, less sodium, less glucose in the body. So they are going to enhance the excretion of glucose, right, by inhibiting SGLT2 in kidneys. Now, SGLT2 is present in the kidneys, yes, but SGLT1 is also present in the intestine. So, SGLT1 in the intestine, it will lead to decrease in the reabsorption, or you can say the absorption of glucose in the intestine. So, this drug, sotagliflozin, it is going to inhibit both SGLT1, which is present in the intestine, and SGLT2, which is present in the kidneys. So what it does, यहाँ पे in the intestine, it inhibits the reabsorption of glucose, or rather I say absorption of the glucose in the intestine, while in the kidneys it is inhibiting the transport back into the body. So both these effects are going to enhance the glucose or level. It is going to go out and decrease the levels of glucose in the blood. That is the role of this. Now, because of this mechanism, not only is it excreting the glucose, if you see, they're also excreting sodium ions. So this is a very, very good drug if patient is of diabetes mellitus type 2, along with heart failure with reduced ejection fraction. Okay, so this is heart failure with reduced ejection fraction. Your drug of choice or the best drugs available are your gliflozin. So not only are they taking care of the diabetes mellitus, but they're also taking care of the heart failure. So one of the very, very good drugs. It decreases mortality in the heart failure patients. ADRs. Now, because most of the glucose is going to go into the urine, so there is a risk of having urinary tract infection. There can be risk of, in females, there can be risk of vaginal infections. Now, it can also, because sodium is being lost, it can lead to hypotension. Very rare, but yes, it can lead to diabetic ketoacidosis. Ketoacidosis, though it is a rare thing. Then long-term use can increase the fracture risk. Now, it's not gender-based here, so it will just increase the fracture risk and weight loss. So, all these things are to be kept in mind when we are studying about the SGLT2 inhibitors. Other drugs which are there, like alpha-glucosidase inhibitors. So, basically what they're going to do, they're going to inhibit the breakdown inhibit the breakdown of complex carbs into simple carbs. So therefore, there is no absorption. So it is not going to be absorbed easily into simple carbs. Main adverse effect because of this, which is very common, disturbing, is flatulence. It's the most common. Also, there can be diarrhea because of this and pain abdomen. That's why it is not, patient don't really tend to take it that often because of flatulence and this. Amylin analog, which is pramlintide, it will help in decreasing the blood glucose levels. Yeah, blood glucose levels. And it also delays gastric emptying. Now, this is one drug which is approved for both type 1 and 2 diabetes mellitus. Most of the other drugs, because they are mostly approved for type 2, why? Because their insulin dependent actions are there. In type 1, the insulin is deficient. So therefore, this is the drug which is approved for type 1 as well as type 2 reactions. So the major adverse effect will be like nausea, vomiting. It can also cause weight loss because of delayed gastric emptying. Then bile acid sequestrin, cholecalciferol, they are going to inhibit the absorption of glucose from the gut, decrease glucose absorption from the gut. Dopamine 2 receptor agonist, the new one here is bromocriptine, which is also this newer use has come up. Why? Because it takes care of the circadian rhythm, right? So it takes care of the circadian rhythm. It sets the circadian rhythm. Newer drug group is glimins, which is imiglimin. Now, it has a very unique mechanism of action that they act on the mitochondrial level. Mitochondria. And therefore improves the beta cell function of the pancreas, and it increases the peripheral utilization also, peripheral glucose utilization. So it's a newer drug group with a distinctive mechanism, so how likely that it can be asked in future examination. Acts on the mitochondria, improves the beta cell function, and also increases the peripheral glucose utilization. Can cause nausea, vomiting, and fatigue. So, of all the ADRs you've done before, so let's see if we can solve this MCQ. Which of the following anti-diabetic drugs is linked to an increased risk of fracture? Now remember that we have done it with glitazones also, we have done it with gliflozin also. But if it is not specifically gender, the gender is not there given. So we would like to mark gliflozins until as especially female predisposition is asked. Then we will mark the pioglitazone mostly or the glitazones as such. So out of this, the confusion will mostly be in glitazone or canagliflozin. We will mark canagliflozin because there's no particular ask in the question, no females have not been mentioned here. Now we come to the next drug which can be given apart from the drugs is apart from the anti-diabetic drugs as we have insulin. Now insulin is the drug of choice for type 1 diabetes mellitus, but it's an add-on to the type 2 diabetes mellitus when the drugs are no longer sufficient to take care of the blood glucose levels, or if there's an emergency like diabetic ketoacidosis in pregnancy also we give this. So that is where we use them. Now let's do the insulin, classify the insulin. It is classified into rapid acting, it is classified into short acting, intermediate acting, and long acting. So rapid acting insulin, these are three. So you can remember GAL, rapid GAL, glulysin, lisproaspart, and these are usually given just before meals, the 15 minutes before meals, very, very rapid acting and have a short duration of action. 15 minutes before the meals you give them, and given by the subcutaneous route. And major drawback with insulin would always remain with insulin as such. It is hypoglycemia, and insulin also causes hypokalemia. Therefore, insulin can be used in the treatment of hyperkalemia. Remember, this is common for all. Okay. Then we have short-acting insulin, regular insulin. So, it needs to be given an hour before the meals. Remember, this is the only insulin which can be given by IV route for diabetic ketoacidosis. Otherwise, most others are only suitable for the subcutaneous route. Then we have the intermediate acting insulin. Now, the first two, the rapid and the short acting, they mainly take care of the post-meal hyperglycemia, right? Postprandial hyperglycemia. So, that is, you can take what you call is at the bolus regime, just before the meals. The intermediate and the slower acting drugs, they take care of the basal levels of insulin. So, that's called the basal regime that they take care of. So, we have a basal bolus regime, right? So, what is a basal bolus regime? Where we combine a short acting or a rapid acting drug with the intermediate or long acting drug. So, one takes care of the post meal hyperglycemia, the other takes care of the basal hyperglycemia glucose levels. So, in the intermediate levels, we have NPH, neutral protamine hegeton, also called as isophane insulin, and we have a lente insulin, which is combination of two, 70% ultra lente, 30% semi lente. This NPH, it is a cloudy white preparation. Okay. Now, this long acting insulins, all of them, they are also called as peakless insulin. They don't have a peak because they have a sustained and uniform action. So, they are peakless insulins. So, the action is somehow like there's no peak. While the ones which we talked about before, the bolus ones, they do like this. So, you give them before every meal, right? So, it is the breakfast, lunch and dinner. This is the graph you get. So, this is a peak here, and this is the bolus, which takes basal, which takes care of the throughout the day levels of your glucose. So, we have here insulin detimer, glargine and degludec. Degludec is the longest acting. The action can last for about 42 hours. So, just give once a day, or that is enough in most of the cases. Now, glargine, important thing you have to remember is this cannot be mixed with any other insulin, right? So, because it is acidic in nature, pH is 4, can't be mixed with any other insulin because it will crystallize. Okay. Complications of insulin therapy, apart from main, it is hypoglycemia, and yes, it was hypokalemia. So, what is actually advised to the patient is, because it is applied subcutaneously, that the patient will regularly change the site where the injection is even applied. Otherwise, it can lead to this condition, which is called as lipodystrophy. So, lipodystrophy is there. Now, the sites of insulin injection, there are many sites, like you can apply it in the abdominal area, on the upper outer arm, on the buttocks or upper outer thigh. So, these are the various sites where you can give injection. Now, remember the absorption. The absorption occurs best in the abdominal area, followed by the arm, followed by buttocks, followed by the outer thigh. So, remember, this is the way. So, preferably our abdomen, otherwise arm, buttocks and then the thigh. So, these are the important take home points from the anti-diabetic drugs.